Now, I don't get to quite leave yet because I have the great pleasure of introducing our next speaker, and that is Tom Trauer. And we're very fortunate to have Tom here with us today, and Tom's been a great colleague for us and supporter of our work in Interpo and in New Zealand. And Tom is, I would deem, an expert in the outcomes field, as many of you will as well. Tom trained as a clinical psychologist in Melbourne and worked in public health, adult mental health services in Melbourne and London. As of 2012, Professor Trauer has 184 publications, most of which are in peer-reviewed journals and numerous unpublished reports, seminars, workshops and conference presentations. He's refereed papers for many professional and scholarly international journals. Recent and current interests include mental health care, palliative care, outcome measurement, assessment of need, quality of life, service evaluation, and providing methodological and statistical advice to trainees and colleagues. His major recent area of activity has been in the field of outcome measurement and mental health, where he's recognised as a national and international expert. He serves on national advisory committees on mental health outcomes measures and is editor of the book Outcome Measurement and Mental Health Theory and Practice that was published in July 2010. It gives me great pleasure to introduce our keynote speaker, and please welcome him to the stage, Tom.
The brief I was given today was to talk about, not about outcome measurement per se, but about HoNOS specifically, because I know that that's the main tool that you use here. So I'm going to focus on HoNOS, even though I believe that outcome measurement tends to be, in many parts of the world, wider than that, but it's going to be about HoNOS. And in terms of HoNOS, most of my experience is with the adult form, not so much with the children's form and the older person's form, so a lot of the material will be about the adult HoNOS, although some of what I say can apply to some of the other measures as well. And I understand that what you want from me is really a kind of a state of play as to what is known about this instrument, particularly from the kind of what is known in a solid fashion, which is published and repeatable and rather than some of the more anecdotal stuff. So, given that I'm an academic, that's the approach I'm going to take. This is the list of things I'm going to try and cover. Talk a little bit about psychometrics, because it seems to be kind of an inevitable topic when we talk about this instrument. I'm going to talk a bit about the assessment of change, the relationship between HoNOS scores and service use, the suitability of this instrument for assessment of Indigenous consumers, a little bit about what people think about the HoNOS, which I call stakeholder views, and clinical utility. And after that, I've got a few concluding observations. So that's really I'm going to work my way through those headings. So to start with, not necessarily the most interesting topic, but it is important. Psychometrics, which usually when you hear people sort of say that express doubts about the HoNOS, usually psychometrics is not far away. So it's a fairly sort of popular and easy way to criticise HoNOS and also sometimes to criticise outcome measurement more generally. And what is usually being referred to here is reliability and validity. I won't go into a great deal of sort of technical detail as to what these are. Reliability means, is it accurate and dependable? Validity means, is it measuring what it claims to measure? And if you actually look at the literature, much of which I've contributed to myself, most of it actually relates to validity. And it's usually about the easiest form of validity to measure, which is internal consistency. That is, if you've got a multi-scale item, all of the items should be pointing in the same direction. And internal consistency is a measure of that. Easiest form of reliability to measure, because all you need is one assessment. Given that one of the main uses of outcome measures is to assess change, it's interesting that there is very little evidence available on test-retest reliability. It's really on, do the items of the HoNOS hang together in a way that a multi-item scale should. And the evidence is that they do a bit. Reliability is usually measured from 0 to 1, and acceptable reliability for instruments like this is usually around 0.7, and most of the estimates are around 0.7 or a little bit below, which means that the reliability is kind of marginal. It's not good and it's not bad. It's kind of in a bit of a grey zone. And the measure I'm talking about is the HoNOS total score. That is, when you give all the 12 items, add them up, get a number, it's that I'm referring to. And why should this be? Well, it's not clear that the instrument itself is measuring a single entity. The HoNOS was always designed as a multi-item scale with a wide range of coverage, with behavioural problems and impairment problems and symptoms and social functioning. So it's quite possible to get people scoring badly in certain items and well in other items. So the reliability is a bit weak, the total score. Interestingly, though, validity has never been, as far as I can see, seriously challenged. Everybody thinks that the HoNOS probably measures something called overall severity of mental health condition, and nobody has ever sort of seriously questioned that it does that. If you read through the 12 items, they seem pretty appropriate for people with moderate to severe mental health problems. That's as much as I'll say about psychometrics. One can go on all day. In fact, I frequently do. But I'm a guest in your country, and I will spare you that. I'll talk about something which is, I think, generally of more interest to people, which is the assessment of change. HoNOS can be used for multiple purposes. If you just give it once, you'll get a one-off cross-sectional today assessment of severity. And there is some value in doing that. But I think as an outcome measure means, does the person do well or do badly or stay the same? And in order to answer that question, you have to have more than one assessment. So assessment of change is actually quite important, and there's been actually quite a lot of work on this. Certainly in Australia, and I think here, the occasions where the HoNOS is administered are referred to as episodes of care, and you would generally have assessments at the beginning and at the end, and under various kinds of rules along the way as well. And I'm going to talk about assessment of change in two ways, because you can look at assessment of change in groups of people. That is, does the average improve or stay the same? And then you can look at change in individual consumers. And even though some of the data is going to be the same and some of the methods are the same, the methods are actually quite different. So you've got to sort of use the same data in slightly different ways. So to start with group change, a lot of work has been done in inpatient settings, and on the right there you can see a number of publications. The font's probably too small, but there's been a number of publications giving the average admission score and the average discharge score in inpatient settings. And you can see, I've just drawn the lines there, the evidence is actually is really quite consistent. People come in with high-ish scores between about 12 and 17, and they go out with much lower scores between about 7 and 12. What is interesting here is that in inpatient settings it's actually quite easy, that the HoNOS is actually quite good because it's quite easy to show that people on average do get better. And the fact that all these lines are really quite parallel suggests that the proportion of improvement is pretty much the same across these settings. These settings are mostly Australian, but they include New Zealand, and they are public and private sector settings. And it appears that in most studies, it looks like the HoNOS score on average goes down by about 50%, which is really quite a lot. There's comparable studies looking at community settings, and there the change is much, much smaller, of the order of 10% to 30%. So people come in with very high scores, and on average they go out with scores which are about 50% lower. This is the simplest form of assessment of change that you can do. You need at least two measures. More is better. We rarely have more. There's been very, very little work done on looking at change beyond just beginning and end of episodes. Probably because the beginning and end are probably the most important, and also because that's the way you're going to see the biggest change. So, it's easy to detect the change between the start of an episode and the end of an episode. If you look at individual change, the story's a little bit different. It requires, as I said, slightly different methods. And the reason is that because of its rather sort of marginal reliability, the HoNOS total score, if you just sort of consider it as a number, it's got a lot of noise in it. If you get a score of 13, it could be 15 and it could be down as low as 11. You see 13, but there's a range of noise around it. In group studies, it's not really important, particularly if you have very large groups, because a lot of the noise will cancel out. But when you're looking at an individual, whether an individual change, that noise is important because it doesn't cancel out. So it's actually much harder to show change in an individual in a robust fashion when you've only got one person that you're doing an assessment of. So where was I talking about individual change? It's more difficult to do in the individual case. This is some data on a real client with a number of HoNOS assessments conducted over about 4.5 years. In fact, so this kind of having more than 2 points is really quite appealing. You can get much more of the bigger picture about how the person is tracking over extended periods rather than the rather sort of artificial periods which are captured by the episode. In order to understand peculiar blips, you do need additional information. But the trouble with this method is that it's very hard to automate. This took me one whole evening to produce this, and I don't know of any easy way of automating this. But it shows that there is potential in measures collected over extended periods, whether it's the HoNOS or any other instrument. The trick is to somehow use it and put it into a form where you can actually look at all those periods. And as I said, up till now, haven't discovered any easy way to do it. Now let's see. Oh, it works. Good. Many of you will be aware of a thing that was developed in Australia by AMACAN, the Australian Mental Health Outcomes and Classification Network, called the Decision Support Tool, which is freely accessible. That's the website. Anybody can go and play with it. It's actually quite fun. It is, of course, just Australian data. It's probably valid for use in New Zealand. I don't think the differences would be that great. And what it looks like, you get a front screen where you specify your query. You say whether you're interested in the whole nation or just certain states. whether you're interested in adults, children or older persons, which instrument. Of course, we use more than one instrument in Australia, but here I've put the HoNOS. You can actually say whether you're interested in the total score or any of the item scores. You can say whether you're interested in one-off assessments or transitions between points in the episode. And if you say episode transition, which I put up here, then it'll say, well, which transition are you interested in? And almost always that's admission to discharge. If you have a client with an actual change, you can actually specify that to see where that sits. And you can specify the setting, inpatient setting, and age, gender, and diagnosis, and all of that. So you work your way through that, press the button, and you get something like this, which on the right it just repeats the specification just in case you forgot. And what this says is that there are about nearly 25,000 assessments in the system of episode transition between admission and discharge, people in inpatient settings with a total score on the HoNOS, inpatient setting, what else? With a diagnosis of schizophrenia or related disorders. And there's the distribution, tells it the average change is 7.9, median is 8, standard deviation, all of that kind of stuff. And if you've got somebody with a score of 5, it'll tell you that that's at the 38th percentile. And if you're not sure what that means, there's some text at the bottom telling you that 38% of those assessments are less than 5, and the 60, whatever it is, percent are more than 5. Quite a useful tool, which you can access. It's pretty quick. It responds pretty quickly, and you can do little what-if exercises with it, like change the diagnosis or and things like this. So that's quite a useful tool to be aware of for being able to put observed changes into the context of the wider context of, well, where does this fit with other people of the same kind in the same setting. I'm going to press the right buttons here now. There's also a very interesting study which I didn't mention last time because it didn't exist then. It only came out last year by some Italians in Milan, and they produced an interesting thing like this. They looked at 292 clients with first contact, and each of them got 2 HoNOS assessments, and the score of the first one is along the horizontal axis, and the score of the second one is on the vertical axis. And every dot represents a person. And they say, rather complicated argument, but they say, well, about a score which goes from above 10 to below 10 is a clinically significant change. So you've got some lines there indicating a score of 10. And they also say that because of the rubberiness of the HoNOS total score, you need to show a change of at least 8 to be sure that it's a real change and not just the noise in the measurement. So you've got the diagonal tram tracks showing changes of less than 8 inside the tracks and more than 8 outside the tracks. And on the basis of this, they were able to say that about 76% of these people between the first and the second assessment had not changed reliably. I'm not saying it's important to say that it's not that they didn't change. It's saying that the change on the HoNOS total score was less than 8, and if it's not as much as 8, then it's uncertain whether it's a true change. 22% improved and 2% worsened. So this is also a different approach to actually using serial assessments to see whether the difference between the first and the second, or the second and the third, or the first and the third, are of a magnitude which would suggest a change which goes from pathological to not so pathological, which is the significant change criterion, and whether the difference is big enough to be greater than you would expect just because of the reliability of the score. So there's quite interesting methods now where you can actually look at observed changes and try to interpret them. Moving to the next area on the list that I set out before, which is the relationship to service use. And there's very good evidence now that higher HoNOS scores are associated with greater service use, both in inpatient and community settings. This is work that I did a long time ago. About 2,000 HoNOSs I had, and I divided them into the bottom third, 700 HoNOS scores of 0 to 7, the middle third, HoNOS scores of 8 to 13, and the top third, which is scores of 14 to 40. No significance to that, just thirds. And these were HoNOSs, and on all of these people I had the number of bed days that they had in the previous 12 months and the number of community contacts that they had in the previous 12 months. Very clear trend of low scores having fewer bed days, medium scores having 24 bed days in the previous 12 months, and high HoNOS scores being associated with much higher bed use, and a similar trend in community contacts. Very clear, a very clear relationship. Another study, again, I did this sometime later, had a bunch of people, HoNOS total scores on them, and for all of these people, I had not just whether they'd been in hospital, but how many times they'd been in hospital in the previous year. Most of them had not been to hospital at all. 375 had been to hospital once, 120 twice, and so forth. And you can see that there's a clear increasing trend of higher HoNOS scores being associated with a greater number of admissions in the previous year, and the same kind of effect was true for those people with their community contacts. Higher HoNOS total score, more community contacts. One of the service use things which has been of particular interest, and there's quite a lot of work on this, is there a relationship between the HoNOS total score that you have when you come into hospital and length of stay? Very interesting question, because it's kind of, hospital stays are very expensive, and a hospital day is very expensive. So there's several studies on this. And in general, this is Australian data I'm talking about, length of stay was longer in public than in private hospitals, but then, of course, their case mix is very different. And the results are inconsistent. Some people show that there is a relationship, that is, higher score, longer stay. Others show that there's no relationship. That is, higher, lower scores doesn't affect the length of stay. So I was a bit perplexed by this, because you'd think that there should be one answer to this rather than everybody coming up with their own answer. So I had some data in the hospital where I worked, 17-month period a few years ago, from the acute unit, 910 episodes of care involving 631 consumers, reasonably good HoNOS completion rate for the... and what I found was that it's actually some HoNOS, high scores on some HoNOS items predict a longer length of stay, and high scores on other HoNOS items predict a shorter length of stay. And this is what it looks like. If you take item 6, which is hallucinations and delusions, the people who scored 0 on admission tended to stay 9 days. The people who scored 1 on this item, mild, tended to stay about 11 days. People who scored 2, about 14 days. Can't quite read the... And people who scored 4 stayed about 28 days. Very clear trend. Worse score, more severe score on item 6, you stay longer. But then you look at item 7, which is depressed mood. And here, the people who scored 0 stayed nearly 20 days. And the people who scored 4 stayed only about 9 days. An opposite trend. Same thing with deliberate self-harm, which is highly related to depressed mood. Item 1, which is aggressive behaviour, looks like this. So what appears to be happening is that some items, high scores are predicting longer length of stay, other items are predicting shorter length of stay. So the poor old total score, which of course jumbles them all together, it gives you inconsistent or no relationship. So this is one of the things to bear in mind about the HoNOS total score, that it tends to combine into a single number things which might actually be moving in opposite directions, and that I think the moral to this is to be a little bit careful about the HoNOS total score, and sometimes you can get answers with the items which are obscured in the total score. Next thing on my list was using the HoNOS with Indigenous consumers. Not a great deal of work in this, but two things I'll tell you about. And in fact, when I was in Wellington 5 years ago, one of my slides had this very question on it because I've copied it directly. And the question is, do Indigenous subgroups require their own measures, or should we go with the universal measures such as the HoNOS? There's arguments, strong arguments, for and against both points of view. One study was the study that was done here in New Zealand in about 2002. Data was collected over 6 months in 8 of the 21 district health boards, and I had the pleasure and privilege of analysing some of that, which was great fun. Big study, over 12,000 consumers, 19,000 episodes of care, and there was HoNOS start-end data on about 1,250 Maori consumers, about 400 Pacific Islander consumers, and about 3,000 all others, which was anybody who wasn't one of the first two categories. So it was a good opportunity to look at it. And this is a summary of the results. First of all, at all points in time, both in inpatient settings on the left and in outpatient community settings on the right, the Maori consumers were achieving higher scores. They had higher severities. The all other group, which includes the Europeans, Pākehā, and those, achieved the lower scores, and the Pacific Islander groups were in the middle. So it's a repeated finding that the Indigenous groups were getting higher scores. But here again, like in the slide that I showed earlier, it's interesting that these lines are almost parallel. That is, that whatever the starting score was, the ending score in the inpatient settings was 50%. So that is the percentage improvement is about the same for all, even though some people were scoring higher at the start and at the finish. The lines are flatter in the community settings, but here you can see that the average improvement in patient settings for all three groups was about 50%, and the average improvement for start end of community episodes is, I say, around about 10%. Does this mean that the measure is appropriate or inappropriate for Indigenous subgroups? I don't know that this data itself would answer that question, but it appears to be producing data which is understandable. In that study, there was a measure of functioning. The life skills profile was also used, and it got pretty much the same result. So, middle dot point, despite the differences, change in scores as a percentage between start and end of episodes is roughly comparable between all three groups. The other study is an Australian study which is conducted in far north Queensland called the Aim High Study. It's an acronym for something, but I can't remember. And in this study, following training, clinicians used the HoNOS and the LSP over a 12-month period with consumers who came into their service who self-identified as Indigenous, just Aboriginal and Torres Strait Islander. And we used the national protocol that we have in Australia, so the HoNOS was used in admission, review and discharge of acute inpatient episodes and in the community, just the same as you would do with non-Indigenous clients. But with the addition that there were a few extra questions asked of the clinicians, things like how difficult did you find it, do you think the scores were valid, and stuff like that. And one of the interesting things to come out of this study was that it didn't actually say, look, you can use the HoNOS or you can't use the HoNOS, but what it did say was if you're going to use it, or if you're going to use any kind of instrument like this, there are four, we distilled it down to 4 principles which you should observe. One is that the clinician should involve additional informants, which we defined as family members and a local health practitioner whenever possible. Don't just rely on the straight clinical interview. You use these other people. Ratings should reflect underlying disadvantage, even when it's common. So just because over 50% of the people in that particular place where this client comes from have this problem doesn't mean you don't rate it. You do rate it. And similarly, where problem behaviours are common, such as alcohol or accommodation problems, things which are rated on the HoNOS, where they're common, you do rate it. But you don't rate things which in a non-Indigenous person would be odd, but an Indigenous person are understandable, relating to things like certain sort of behaviours around when somebody dies and funerals and things like that. So this is a distillation. This is a summary. The actual principles we took us a lot of work to get the wording right. So just bear in mind that this is my informal summary of the kind of principles that you would need to use if you're going to use a non-Indigenous measure with Indigenous clients. And what we got over our 12-month study was 271 consumers rated a total of nearly 500 times. And despite the training saying use additional informants whenever you can, most of the time they weren't. Whether this was by choice or no opportunity, we don't know. And just like in the New Zealand study, the scores on the HoNOS and the LSP were... Or actually, no, that's a separate point. When the informants were used, scores were higher. So it appeared that if you don't use informants, you're likely to miss things that you would find out if you'd spoken to somebody else who knows the client well, such as a family member or a local health practitioner. Very, very strong effect there. And even though we didn't have non-Indigenous data from the same area, we could go to the decision support tool, which I described before, and say, well, for this bunch of people, with this age and gender breakdown, what would be the item scores? So here the continuous line is the profile for the Indigenous clients, and the dotted line is for what I call the national comparison. And you can see that the consumers, the Indigenous are scoring worse on items 1, 3, 4, 6, 10, 11 and 12, about 7 of the 12 items. They score about the same on 2 of the items, 2 and 10, and they actually score better on items 7 and 8, depressed mood and any other problems. Now, I went and checked this with the New Zealand data, very much the same, and it's interesting that there was lower scores than the national average on the 2 items which are associated with depressive disorder, particularly if that would mean that depression, which is sometimes difficult to judge is being under-detected by the HoNOS in these specially trained workers. Just sort of conscious that I've got running short of time, but I get the time back from when you have the system breakdown. I've got 42 slides, and this is number 33. A little bit about stakeholder views. What do people think about the HoNOS? A lot of work on this, a lot of work. And I'm one of the main culprits, I'm afraid, of producing that. Very interesting to compare the views of different stakeholder groups, such as consumers, clinicians, managers, and policy people. What almost all of the studies find is that there's a very wide range of views. This is a study that I did where I gave everybody a questionnaire and asked people what they thought of these measures, including the HoNOS. And there are some people over on the left that think all of these measures are absolutely terrific under all circumstances. And at the other end, you've got another bunch of people who think that all of these measures are completely hopeless for anything. And you've got a whole lot of people in between who think, yeah, kind of good, no, kind of not so good, or just can't decide. This is a typical finding, absolutely typical finding. So then the question is, well, is it possible to identify the people who think it's good and the people who think it's bad? And most of the studies, not absolutely 100%, but most of the studies show that the medical staff are the most negative. When you ask everybody the same question, you get the averages, the medical staff are the least enthusiastic about the HoNOS. Administration, management staff are generally the most positive. Well, they don't have to fill it in, do they? So there are some reasons like that I think. And also they get the benefit in ways that they get the data which helps them to administer and manage. What are the factors associated with thinking, being positive towards this instrument? Well, things like availability of fast and useful reports. Fast reports is not so difficult these days. The information systems are fairly fast. Useful reports it's a bit more unclear. Behavioural modelling by senior staff. If the psychiatrists and the consultants don't like it, then you tend to sort of think, well, they should know. Maybe I shouldn't like it either. And also caseloads. HoNOS takes time to fill in. If you've got a large caseload, it is a significant amount of time. Finally, in terms of my list of specific topics, I'll talk about utility. When outcome measurement and HoNOS was first sort of thought to be a good idea, the idea was that they should be useful. And most of the literature asks people about utility, but doesn't specify utility to whom, which is the important thing. It might be useful, but maybe not to you. And most people will answer questions about, is outcome measurement a good thing? Well, outcome measures could be useful, and they should be useful, but whether they actually are useful to that respondent is sometimes not spelled out. I like to think of distinguishing utility from clinical utility, because there's a lot of things that you can use these measures for. Some of them are clinical and some of them non-clinical. Things like, I think I'll list them here, benchmarking, key performance indicators, case mix. Some of these activities, useful as they are or may be, are not actually clinical, not clinically useful, not clinical activities. And so what the literature tends to show is that a lot of the positive about the positive attitudes towards HoNOS comes from people who have applications such as these in mind as part of their work. Not so clear that the people who are actually doing the service provision find them as useful. Come on. That's what I just said. I think of clinical utility as referring to usefulness at the clinical interface, that is, to the service provider and or to the service recipient. And what I think, this is well spelt out in that excellent book that was referred to earlier. Clinical utility, what is it? Promoting dialogue, tracking a client's progress, identifying hidden problems and needs. It's interesting that sometimes these measures, you get results that which are unexpected. Promoting self-efficacy and recovery, and helping with the development of service plans, and informing clinical decisions. Evidence of whether the HoNOS is useful in these kinds of purposes exists, but there's not very much of it, and a lot of it tends to be anecdotal. So the evidence, from my rather sort of academic point of view, is a little bit on the weak side. A couple of slides on concluding observations. I've just been talking about HoNOS. I said here 5 years ago that I don't think my personal point of view is that HoNOS is just part of a broader thing called outcome measurement. And I tend to not like to equate HoNOS with outcome measurement, even though I know that this is the only instrument that is formally in use at this time in this country. The areas of concern with the instrument, I don't want to belabour the concerns, but it's an imperfect instrument. We have some concerns about the robustness of the assessments. Is the HoNOS strong enough to support funding formulas such as case mix? How to assess change meaningfully. I've shown you some examples of how that might be done. How to assess Indigenous clients using some of those principles seems like a good idea. And in settings where we use more than one instrument, what happens if you get one story from the HoNOS and another story from a consumer self-report? Where does the truth lie when multiple instruments give you rather different stories? The HoNOS is a very easy instrument to criticise, and a lot of people have got some rather cheap shots at the HoNOS. But then you have to think that every instrument is imperfect. There is no perfect instrument. They've all got their strengths and weaknesses. Too long, too short, too this, too that. It's got its own imperfections. Some years ago, myself and some others did some work on saying, well, maybe some of those imperfections can be corrected. Maybe we can sort of fix it up a bit. And there was a document produced, but that didn't lead anywhere. It would have required a number of countries to agree to cooperate and pay money, and none of them thought that they should do that. So I think while people support the idea of outcome measurement but criticise a specific instrument, I think it's legitimate to ask what alternative form of objective measurement do you support? Because I think whatever measure you're going to use, you're going to have to make compromises. All measures have weaknesses. So if somebody says, well, I don't like this measure, you should say, OK, then, well, what would you use? Thank you for your attention.